Hello, hey Sai, can you hear us?
Hi, Sushil. Good morning. Who all are there on the panel?
Hey, it's Ashish. How are you doing, buddy?
Hi, Ashish. Hi, Sushil. Thank you so much. You guys are bang on time. Incredible.
We're going to ask you to be on time too, so be careful.
So very quickly, without ado, this is Chennai, Apollo Hospitals. And the team here is, to my right, is Dr. Vijay Kumar. And to his right is Dr. YVC Reddy. And Ganapati is on TE here, along with, I think, Balaji or Karthik, one of them. Our cath lab tech, Mail. We have two doctors from Iraq who are here on a structural fellowship, Dr. Bawa and Dr. Muhammad. They're watching. And the patient we have today, I'm going to allow Vijay to speak about the patient, and I'll get you up to speed. As you can see, this is exactly where we are. It's live MPR. But before I go further, Vijay, could you introduce the patient, please?
Yeah, good evening all. Our patient is a 75-year-old male, is a diabetic, hypertensive, known to have cardiomyopathy, chronic atrial fibrillation, and he presented to the outside hospital with AF, fast ventricular rate, and refractory heart failure, and he was transferred to us for further management. When he presented, he had a multi-organ heart failure with multi-organ dysfunction, with elevated liver enzymes, elevated creatinine, thrombocytopenia. And go to the next slide. He was here with us for more than 10 days in ICU and gradually improved, and his thrombocytopenia recovered, renal and hepatic function improved, and his rate also got under control because he had very low blood pressures and we had a lot of difficulty in controlling his rate. And after medical stabilization, we did a transthoracic echocardiogram, which showed global hypokinesia and dilated left ventricle with LV and diastolic dimension of 6.2 centimeter, in systolic dimension 5.1, end diastolic volume 157, ejection fraction of 28%, severe mitral regurgitation with ERO of 0.4 square centimeter, regurgitant volume 66 ml, and a dilated LA with a 110 ml volume and mild pulmonary arterial hypertension. Move to the next slides, please. And here you can just see that dilated LV with severe LV dysfunction, hardly any movement either longitudinally or circumferentially. And go to the next one, and maybe Dr. Sai can go ahead with this.
You can see this view, torrential MR, and can you play that MR slide once, please? Yeah, just play the slide. So you can see torrential MR, sick patient, cardiogenic shock. He was very difficult to handle the first 2 weeks, thrombocytopenia, pressures barely holding, but we finally got him stable enough for the procedure. He's here on table. Ganapati, you want to just show the echo, the stick?
Live echo.
The live echo?
So can I ask a question here?
Sure.
So this is, you think atrial and ventricular functional MR, obviously, the guidelines in the U.S. we talk about heart failure management, but this is a clear example where, this patient's sick in the hospital in shock, and this is it's a different type of patient than an elective outpatient heart failure optimization candidate. How do you approach the decision of MitraClip? I mean, do you have a heart failure team? What is the decision-making process, just for the people in the audience?
So this patient is a known patient of cardiomyopathy with atrial fibrillation for over 15 years with follow-up from his treating cardiologist. He did well for the first 10 years, but over the last 5 years, he's been having progressively worsening heart failure hospitalizations. From January to now, he's had 6 hospitalizations on maximum medical management. He got admitted to the other hospital. In spite of all anti-failure measures, they could not hold his failure. Liver enzymes started going up, kidneys started going down. At this point of time, the treating doctor there reached out to me and said, look, the MR is almost free-flowing. He's very sick. There's no cardiac output. We're not able to manage him. I said, shift him. When he came here, we gave him IV dobutamine. We gave him IV Lasix, gave him some NORAD to prop up the pressures. 10 days in the CCU. The team here is quite good at dealing with these low EFs because we've done a significant number of these cases. And I know I was supposed to show a degenerative case today. That's what was on the agenda. But I thought this would be a great case to show, to see how the sickest patients can still benefit from this therapy if you choose them right. So the heart failure team maxed out. They were not able to hold him on GDMT. And he was referred to us for further management with device treatment.
I think that's great.
Yeah.
Okay. So I think, shall I just go ahead and tell you where I am right now?
Sure.
So what happened is that we had, it's a large heart, as you can see, Raj LA, Raj RA, EF pushing barely 20%. We took a good stick. I got a 4.2 centimeter stick. I thought I should come lower, but it was in a nice position. So I took the stick, but the heart was quite rotated. And what happened is, as I started trying to navigate towards the valve with the clip, the valve started hitting. As I tried to push it in to go more lateral, the whole guide rode up and hit the roof of the LA, and the device started skewing. So actually, it's not often, but you know what I mean? I actually had to use the P knob and anterior guide torque to lose height and to get it to exactly where it is. Now, Ganapati, can you show exactly where we are now? Just show a bicom with LVOT. So if you look at it now, it looks nice.
So Sai,
Perfectly
can you show us a 3D of the valve pre? Did you get that? Or
Yeah, of course we did, Gana. 3D of the valve.
before
So
you start?
While we wait for Gana to give the 3D of the valve, very quickly, Gana, just show the recorded 3D of the valve. Any choice of clip here? You guys have seen the leak, you have seen the anatomy. NTW, which like traditionally, or XTW, what would you go for? Sushil Ashish.
Did you measure this is Ramesh Sai.
Hi Ramesh, how are you?
Yeah, very good. Thank you. I mean, I think it all depends upon the length of the leaflet on the posterior side that you can see.
So the leaflet is 1 centimeter on the posterior side.
Right.
The non-coarctation gap was about 0.5, 0.6. The anatomy is large. The valve area is about 7.8 to 8 centimeters. I felt it'll be better if I take a XTW as the first clip and then take it from there. That's your 3D of the valve.
So, you know, before you said that, I was going to say XTW, but since I can't agree and you decided to give it in advance, I would go the opposite. No, I'm just kidding. No, one thing I will say, I've become more of a convert to XTW. I've always had concerns. Early on, we had tethered leaflet where XTW, and I think we grabbed too much and the tension was too much and we had a detachment. And so I got nervous about it, and I think, and I sort of moved away. But over the last year, I've been using XTW because I think the amount of, you know, bringing the coaptation back, you can actually reduce annular dimensions. And also, I think you just need to learn the technique better of, you know, being perfectly on
perpendicular with the coaptation plane.
Yeah.
So absolutely brilliant point, Sushil. So the important thing here is that with the XTWs, it makes your life really easy, but you have to understand you have large arms. And if you don't get your coaptation line right, you're going to distort the valve and cause all kinds of trouble. The second thing is that of late, what I've realized, I keep looking at the posterior leaflet and my posterior clip arm. I never allow it to ride above the hinge point. So if I get to a point where I keep giving back, but it still starts pulling too much in, sometimes I don't close the clip fully 100%. I leave it at 80% closed and leave that much back. And these patients actually do very well. Sushil, any thoughts on that? Because we have spoken for 10 minutes. I want to jump in and move the case.
So I just want to say one thing, though, for the people in the audience that aren't familiar with MitraClip. So XTW is longer, and it needs about a centimeter of leaflet length. It has 6 rows of tines or grippers, whatever you want to call them, whereas the NT has 4. But having 6 doesn't mean you just have you don't need to grab all 6. The last 2 are not as robust, so you can't put an XTW and get 6 millimeters of leaflet in there. You won't get good leaflet capture, and you can get leaflet detachment. So if you're using an XTW, you have to have the leaflets and get it to the base.
And the other thing, Sai, that I would caution when you use an XTW in a case like this is I definitely dissuade independent grasping, because that's when you can really cause trouble, because you try to, especially if you have an aorta hugger and you come in a slightly awkward angle, you're tempted to grasp one leaflet and then swing over. And that's when you start getting into trouble in terms of distorting the valve and having an SLDA related to use of this. And the last thing is, before you release the clip, I always go back to the 3D on fast surgical view to make sure that your orientation of your clip arms is where you intended them to be and they haven't turned while because that's really important.
Completely agree, Ashish. So I'm just going to close the clip arm here now. You can see live 3D. Yeah. Now, if I was a betting man, even before I move this clip, if you look at the LVOT, it's going to curve and dive anteriorly. It's because of all the curves I've given to get it to where it was, because it was quite a bit of work. So what's going to happen is as I go lower down, it's going to turn and go anteriorly, but I don't have much of a choice in this anatomy. So I'm just going to have to pull it back and make sure that when I'm under the valve, I'm perfectly positioned for the grip. So I'm just going to go forward. Can you take color off, Gunnar?
Yeah, try that. If not, I think you can put a positive on the
So
guy.
do you see that?
Right.
Do you see it turning
Right.
slightly anterior?
Yeah.
So I'm going in.
What was the
sit.
gradient before? I mean, one of the points
One
was,
sec, Ramesh.
yeah. I mean,
Will
for the-
you take the, it's okay? Enough? Okay, I'm going to open the clip arms. Gonna hold the view.
You see it
Huh?
pull up as he opens because it always drops.
3D
as
and
you open.
false.
the orientation, I think, is a little bit off, but
Yeah, yeah.
It's
So not off.
Fluoroscopically it's changed, yeah.
he's
I
going-
told you, right? It's going to twist.
right, yeah.
Okay, so give me 3D and false.
I also noticed that you have a separate pigtail in the left atrium there.
Always do, because even before anybody knows, my echocardiographer, anybody else knows, my LA pressure will tell me I'm entangled or I'm hitting something. So it's my guiding beacon. It also tells me how the patient is going to be doing hemodynamically. I think little clockwise I have to go. Do you agree, guys?
Yes,
Yes,
yes.
yeah.
We'll make sure Saibal knows that. He's not next. I'm sure he'll be very thankful and appreciative of what you just said.
Yeah, for the audience, I think NTW, XTW also depends upon what's the gradient you started off with. If you started off with 4, I would be like cautious in trying to put an XTW,
Okay.
or even W.
Okay.
That looks pretty good. A little bit more clock, I think.
I think that's
No, it's
good.
I think,
I don't like how it's behaving, huh?
yeah.
I think
I mean, you're a
It's
little bit
not
more.
moving.
It's a little bit more medial than you want, and now because you had so much height, it's sort of
Okay.
you don't have the robustness of that shaft. So.
Huh? I am. I'm going to open a little more.
Yeah, that, I was going to say flip open.
Okay.
A little bit anterior guide torque. Yeah. Pull up a little bit. Your posterior is already falling on the gripper.
Yep. Okay. Is that okay? Guide anterior.
Yep.
I think my posterior is stuck on my clip. Do you see that?
Yeah,
On
no, I
the
agree.
gripper, yeah.
And also, if you look in that left paint, you have a lot of stored tension going medial. And
Yeah.
fluoroscopically as well, it's
Diving medially, yeah.
Yeah.
but also you have so much length because the issue you raised earlier, where you had a lot of height with this stick, it poses the challenge because the left atrium is so big.
So you can see my leaflet is stuck.
Yeah, I would invert
I would,
and come back.
I would go anterior.
I am. It's not
but
moving.
It's not moving.
Yeah.
It's stuck. You see, there's so much.
Yeah, but
No, it's not moving down. Okay.
just cycle the gripper.
I am. Just hang on. So what has happened is this clip, there.
There, you're free.
I'm free. Yeah, I know. Explain. So this is a lot more challenging than I expected. So I'm
No,
not
look at
talking nice.
that. That's pretty good.
No,
that
that's
looks
very
really
good.
good.
I mean,
I'm going to get more posterior.
You ended up more mid A2 P2 now as well,
Yeah.
so that's good.
I know.
That's good.
Check the 3D and 4. So what I have to do is while pulling up, I have to correct 2 trajectories simultaneously because it was stuck. But I'll explain what I did. Let's just look at the 3D and 4. I want to get this baby in place. Hey, please feel free to jump in and tell me any input, but I think it looks good. Can
Yeah.
I drop the gain?
I mean, I would be a little bit more anterior. I think it's.
Maybe counterclock a hair here,
making
right?
sure,
Yeah.
I'm doing that, I'm doing that.
You're right in the middle of the valve now, which is fine. Those
Which
are-
is fine, I'll optimize with the second clip, guys. I'm not messing around with this one anymore. Okay, good. Okay, I think that's okay. I know I'm too open, but Gana, can you go to BICOM LVOT? You guys are happy with the clip position?
I mean, if you're going to put two, do you want to come a little bit more medial or?
Hang on. You want me to go a little more closed, Sushil? You think it's better?
To medial. If you want to put a second one lateral, it's just easier.
Yeah, one sec. Is that okay now? No, just wait, Gana. What do you think?
Yeah.
I think you could try it here. I think
Huh?
your initial goal had to be a little bit more medial, but you might get a good result here.
Yeah.
One minute, look at the leaflets, okay?
No, the leaflets are good. We are questioning about. Go back
No,
to.
I know. I'm just going to give a little plus and let it go a little more under that PML. See that? There. That looks beautiful. Do you like it?
I think
Guys?
the leaflets look great on there. They're
Okay.
good base, but
Okay, so shall I drop grippers? Any suggestions?
yeah, I would drop, but I wouldn't close yet. I would drop and close like 30 degrees and then look on your 3D again. But I think this is good.
Okay.
Yeah.
Because again, when he closes, he does not want to have that come above the
Okay.
hinge point of the valve, because that's when you get
Okay,
in trouble.
guys, I think I have enough of both the leaflets in. Gana, do you want to now look at color and see where I am cutting the jet exactly?
So this is where I would go, yes. Color is one, but
Hang on.
I would go 3D on first now to see if your location of your orientation of your clip is where you want it.
I already know where it is. I already think I know where it is. I'm just going to lock the clip here because I'm happy with this. Hang on. I already know where it is because on both views I can see I'm bang in the center of the jet, but I'm going to go 3D enforce for the panel. 3D enforce. Tell me, Ashish, happy?
Very much so.
Gana, they're going to take me off in 10 minutes. Can you go to BICOM LVOT? I want to close this clip. Okay, so you can see the nice tension on both the PML and the ML. So as I'm closing, I'm going to give back nicely. This is a big clip. We have to be very cognizant of the huge arms that it's got. And I'm not going to close more than this. From 38, my LA pressure is down to 26. Gana, you want to check the MR?
So I just kind of, for the audience to illustrate, for people that don't do a lot of MitraClip, part of the issue and where you get into trouble is, if you close, your clip is, your arms are wide like this. And if you just close, you're going to bring the leaflet above, because you pulled up to the annulus in this functional patient. And so if you try to close, then that arm is going to come up above the annulus, and that's where you get tension, and you can tear and distort the leaflet. So that's why, as he's closing, he's pushing down, because
No. So you can see there's a small jet medially. The lateral jet is fully gone, but I'm not fully tight. So I think
you would need a second clip anyway if you want to go after that pizza.
I agree.
So, and we
So
knew that you were in the middle of the valve and there was a likelihood that the remainder of the jet would be on the medial side. That's why Sushil was saying maybe you should try to put this clip a little medially so the second clip would preferentially be laterally, but I think it's fine.
I'm going to make the counter argument. I'm going to make one counter argument though. I think you deploy this clip and reassess. Look at pulmonary vein flow.
Yeah, I agree.
Because this low EF, you may not.
Yes,
this
you
may be
may not
adequate.
have.
Yeah.
I agree.
So the thing is this, his EF is 22%. He had nearly free-flowing MR. At this point of time, I have it bang in the middle. I have stable leaflet insertion. Look at the smoke in the LA.
Yeah.
I'm going to get this clip closed. I'm going to let it go. I'm going to reassess everything. Now, with such a big valve area, it really doesn't matter to me technically whether I have to go medially or laterally. If I need to, I can just take one clip, scooch in there, put it, and get out in 10. But the question is it important? So let's close this clip. If everybody agrees, let's let this baby go. Then we'll have that discussion. Okay. What do you think, Ashish, Sushil, Ramesh?
So I think that's good. The other option to give you time is we can go to Saibal, get the introduction to his case while you deploy this clip and do the assessment and come back to you if you want in 10 minutes.
Sure. Either way, I'm easy.
I agree with you, Sai. I think assessing this and not jumping to just put a second clip, I think wait for some time. There's a lot of smoke in the left atrium as well.
But the key though is to release this clip and then do the assessment, because
Absolutely.
otherwise you'll be fooled by the shaft on the clip.
Agreed.
So is Saibal ready?
Yeah,
Can
he's
we-
ready. We'll
okay.
come back
So-
to you, Sai.
So Sai, why don't we do that? We'll go to Saibal, 10 minutes, get the introduction, come back to you in 10 minutes.
Perfect. See you guys soon.
Okay,
Okay. Bye, guys.
bye, see you soon. Hey Saibal, how are you?
Hey, how are you? I was looking at the case, what Sai is doing.
Do you want to give some critiques? I'll pass them on.
Yes, yes, you can. I actually saw it. It's good because I basically created a monster over there. But that's okay. He did well.
We're going to tell him that you disagreed with everything he did.
No. Hey, I actually like the position of the clip.
And
It's a
actually,
good
you know what?
position.
He even has a pigtail in there, so that's good.
Yeah, I know. That's what I'm saying.
Hi Sai, we're back to you.
Yeah, well, we got a very good result. As you can see, the first thing that I want you to look at is the 39, 22 LA pressures down to 1511. So that is one thing that gives me a lot of reassurance no matter how much MR I see. You can see the anterior leaflet nice and stable, nicely in. You can see the posterior leaflet nice and in. There's a small trickle of a jet. When I press fluoro, you can see the clip is nicely moving with the heart, nice and stable. And at this point of time, can you go to the BICOM LVOT view? So at this point of time, I'd like to ask the panel a few questions. One, do you all agree? So do you remember that while I was trying to deploy the clip, I said, let me finish this and then I'll speak. See, what was happening is, as I was going into the LV, the clip had a parabolic trajectory. It was going down, diving anteriorly and twisting. And every time I pulled it back, it unwound and came back. So the key was to go just above the valve, keep it where you want to keep it, then go back down and do the grip, hoping it'll come back. So that was slightly tricky in this case. Other than that, the added small element of surprise where the posterior leaflet got stuck and just the fine movement. See, that's the XTW. It's a big clip, right? And when you're under this valve apparatus, even if the valve is large, you can easily get stuck either on the leaflet or on the subvalvular apparatus. So we got out of that. And now back to the panel. What do you guys think? The mean transmitral mean is now 2. The pulmonary veins are good. The leak is barely there. I think I'm going to let go of this patient at this point. But I open the panel for discussion. Ramesh, Ashish, Sushil.
Yeah. I just think you're done, man. Congratulations for a fantastic result, I feel. I wouldn't do anything more than this. What you have already achieved with the reduction of left atrial pressure and my mean gradient being 2, I think you have an excellent result here. What do you think, Ashish?
I mean, there's nothing to chase. There's really
Yeah.
barely any color. His case is done.
Yeah, you can join Saibal and go to the other 2 clips
So
over there.
what's
You know
the
what?
systolic
Speaking
pressure
of-
now?
Systolic pressure is 110 by 57.
And the pulmonary
Oh.
veins are systolic or?
Yeah, pulmonary veins are systolic. And my only worry about this patient is that look at that LV, right? For me, the next 2 days is going to be murder.
Yeah.
Because the EF is about 12 to 14% right now. And I'm already going to start him on a little dobutamine. I'm going to start him on a little NORAD to keep the pressures up. I'm going to give him Lasix infusion. Managing this afterload LV is the key to sending him home.
Yeah, and I think this is a great result, but as you said, the job's not done. Because now the hard part comes with his management post, with the heart failure management and everything else. And I think even if the leak had been a little worse, I think I would have still
You would have still left it. I agree, Sushil. Because going after perfect in this patient, we had a 127 ml regurgitant volume pre-procedure with a wide jet. Even if I have moderate MR, in this case, I'm not going to chase it. Because even with that MR, he's out of cardiogenic shock. His liver enzymes are normal. His creatinine has come down. He was stable enough for this procedure. So the key is that this is and it's a long-standing cardiomyopathy. My aim is to reduce as much MR as possible and leave him stable. I don't want to even think of what the LV will do if I go out. So suppose hypothetically we had like a 2+ MR. I wouldn't chase it. The clip did glide a little laterally, but we still got away. We were lucky. Sushil, do you agree with that?
Absolutely. I mean, I think this is a great result from where you started. So, and again, it's about treating the patient, not the color, as you said, right? And so this is a great result. So I would stop here. Close up the vein.
And before anything else, I can't tell you how happy I was to see Saibal and him to comment on my case. I was smiling when he said, I've created a monster.
Yeah.
Those of you who don't.
That's wonderful. No, I think now it's time to turn the patient over to the smarter people in the hospital, the heart failure doctors, and let them manage the patient. And
Absolutely. And just one more point before I go. I think the single most important, Saibul's taught me a lot of things, but the sage advice he gave me is the pigtail in the LA. Because the kind of, so my reactions are so intuitive looking at the LA pressure. Even the slightest movement when I'm hitting a chord, even before anything happens anywhere else, I can see the LA pressure jump up and down. And the minute I start closing the clip, the LA pressure starts dropping. It's so reassuring. I think it's a pivotal guiding beacon for MitraClip procedures. I can't impress how useful it is. That is one. And that's it.
yeah, I know that LA pressure reduction there, it tells you the patient is feeling better. Their heart is feeling better, and I think that's an important component.
So one question, I just wanted to ask you, RV function, how is it? And usually in case if we expect the EF to go down immediately after the clip, if it's 28, I wouldn't be surprised that it has come down to 15 or 14. But
Yeah,
if the
the
RV
RV
function is not poor, I would actually keep the patient on nitric oxide,
Yeah, but his RV, Ramesh, his RV function was moderate to severe when he came, as you can tell from the non-collapsing IVC and the up liver enzymes. But we have dried him up so much that he's got mild RV dysfunction. I think he'll do well, Ramesh. I don't think he'll need anything. I just think he'll need a little hand holding for a few days. He'll do well. Ganapati, are you going to extubate him on table, or are you going to leave him till? So Ganapati wants to leave him for a couple of hours, take him back to the CCU and extubate him.
Agreed.
But that is the consensus here.
Wonderful.
And,
Great job. Thank
That's
you.
a great
and,
case.
Yeah.
Wonderful. Sai.
Wonderful
Thank you.
job. Nice demonstration. So we're going to see if Saibo can match your case now and see how
Hey,
better result he gets.
don't get me into trouble with my guru, huh?
Okay.